Good afternoon, folks. My name is Dr. Aaron Barnes. I run the Emergency Preparedness and Response Laboratory here at the Minnesota Department of Health. Today we're here to talk about tularemia cases in Minnesota, particularly an update for this current year. We presented a very similar version of this late last summer, but we still have concerns about this, so we'll present this to you folks. I'll be joined today by Maria Bai from our infectious disease epi group. She'll be talking about the epidemiology portions and also Eric Lundquist, who's our biosafety coordinator here at the lab. But without any further ado, let's go ahead and get started. Next slide, please. So just some administrivia kind of stuff here. This will be about a 1-hour webinar, give or take. We'll try to get you out on time. Co-hosted here by the Public Health Lab here at the Minnesota Department of Health and IDEPC, which is again is the epi version of our team here. There is 1 hour of PACE credit available for folks who are pre-registered. We consider this to be an intermediate level course or a refresher. We do expect some basic knowledge, but this will not be a problem at all for anybody who's paid attention to tularemia in the lab at all for the last few years. So nothing but a thing. Next slide, please. We have no conflicts of interest to declare. We're not discussing specific therapeutic interventions. None of us are getting any funding from anybody else other than just the state of Minnesota, where we already work for. But I do have to note that opinions stated here are our own professional statements and may not directly represent the state of Minnesota or the Minnesota Department of Health. Standard boilerplate stuff for that. So next slide, please. So our course objectives, we're going to discuss the rise in both human and animal cases of tularemia over the last few years. These have been relatively dramatic, and we'll get into some numbers and talking about that. I will also be talking about how the Sentinel Lab testing algorithm works for ruling out Francisella tularensis. Most of you are probably very familiar with this, but just so we've covered all the bases. And then Eric's going to talk a little bit about the biosafety concerns laboratorians face when they're dealing with FT, because it is, of course, a very pathogenic organism. Needs to be done in a biosafety cabinet at all times. Next slide, please. All right, I'll go ahead and turn it over to Maria to talk about the epi side. Maria?
Thank you, and happy Lab Appreciation Week to everyone. Thank you for everything that you do to help keep Minnesotans safe, and thanks for joining us today. I'm going to start us off by just providing us with a broad overview of tularemia in Minnesota. Next slide, please. I would really be remiss if I didn't start with a little bit of history on this interesting bug. So Francisella tularensis, the bacterium that causes tularemia, is a tier 1 select agent, which we'll go more into later. But it means that it's among the biologic agents that present the greatest risk of deliberate misuse. In the past, it's been researched as a potential bioweapon by multiple countries. And in the 50s and 60s, it was actually stockpiled by the US and the Soviet Union as a potential bioweapon. And one reason for this is that F. tularensis is one of the most pathogenic bacterium known. Being exposed to only 10 organisms can cause disease in humans. They actually did some studies back in the 50s where people were intentionally exposed to tularemia, and as few as 15 bacteria got some people sick. Francisella can survive in the water, in soil, and decaying animal carcasses for an extended period of time. But despite this notorious past, we really hope that this webinar reinforces that this disease is a naturally occurring zoonotic disease and that it's endemic in Minnesota. Next slide, please. Tularemia is found throughout the Northern Hemisphere and is starting to creep south as well. You can see that it is here in the United States. Next slide, please. Approximately 200 cases are reported in the United States every year. And tularemia cases increased 60% in the decade between 2011 and 2022 from the previous decade. And it's been reported in every state except for Hawaii. 4 central states, Arkansas, Kansas, Missouri, and Oklahoma, report half of all the cases in the United States. But Martha's Vineyard in Massachusetts also has a lot of cases, as does the West Coast. And you can see on this map that although we aren't one of the most popular states for tularemia, Minnesota definitely does still report cases. Next slide, please. And really, no part of the state is spared from this. Over the past 10 years, cases of tularemia, whether in humans or in animals, have been reported from every region of the state. That being said, the majority of our cases are identified in the Twin Cities metro area. Of course, that's where there's a higher density of people and animals, so that part plays a part in it. Next slide, please. But more than just that, the Twin Cities metro area also has perennial hotspots. There are some hyper-endemic areas where we see human and animal cases reported year after year. Cats that live a couple houses down from each other have tested positive years apart, and humans have also been in these endemic areas. And we don't exactly know what that is, but just seems like the bacteria might be present in the rodent and the tick populations in those areas. Next slide, please. F. tularensis has a wide range of ways to infect its hosts. A person can get sick by ingesting contaminated water or tissues from an infected animal. The bacteria can be aerosolized and enter the body when people breathe it in. This can happen when people mow over a dead animal, through soil disruption, grinding up of infected carcasses, or even just the hissing of infected cats. The bacteria can enter the skin through contact with mucous membranes and broken skin. Insects are the most common mode of transmission in the United States, though. Several tick species can transmit the bacteria, but here in Minnesota, the primary vector is the American dog tick. And the deer fly is the most common biting fly involved in tularemia transmission. Next slide. And due to the low infectious dose and the ease of aerosolization, Francisella is also a risk to laboratorians, which is one of the reasons we're here today. And Eric will talk more about that in a bit. Next slide, please. About a quarter of human tularemia cases are exposed through zoonotic transmission, usually after being bitten or scratched by a cat. But you'll see about a third of our cases are vector-borne, and 20% people are breathing in that bacteria. Next slide. It's fascinating, but more than 200 animal species, both wild and domestic, can be infected with tularemia. These range from birds to amphibians to reptiles to fish. Tularemia outbreaks have been associated with animals like pheasants and non-human primates, and animals like mink, horses, beluga whales, and harbor seals have all tested positive for the disease. However, the primary wild animals are rabbits and rodents. Ticks maintain the bacteria in the population and act as reservoirs. And cats are the primary domestic species we think of getting tularemia, but we've also had more dogs test positive in Minnesota in the past couple of years. Next slide. There are two Francisella subspecies of note. Subspecies tularensis, which was traditionally called type A, which circulates in a terrestrial cycle between small mammals like rabbits, ticks, and deer flies. And this subspecies is found mainly in North America and is considered the most virulent. In contrast, subspecies holarctica, which was previously called type B, is perpetuating in an aquatic cycle with semi-aquatic rodents like muskrats, voles, and other things as reservoirs. So you can see with this why this was historically known as rabbit fever and deer fly fever. Next slide, please. Nationally, tularemia cases are most common in May through September, which is shown on the graph on this slide. That's one of the reasons we wanted to talk to you today, to get ahead of that tularemia season. This season is when we see the most cases because that's when people are more likely to be outside, and so they're more likely to get insect bites or have contact with animals. But of course, contact with animals can happen year-round. Next slide. Symptoms of tularemia typically appear 3 to 5 days after exposure. There are 6 defined clinical forms of the disease. All forms usually have a fever, which could hit as high as 104 or even higher. Other nonspecific signs include chills, joint pains, and headaches. But then the very specific clinical form of the disease is tightly tied to how someone is exposed. So for instance, if someone gets tularemia from an insect or an animal bite, they may develop ulceroglandular or glandular tularemia, which is swelling of the regional lymph nodes with or without an ulcer at that site of exposure. If they're exposed via their eye, they'll get oculoglandular tularemia, which is an eye infection. And if they get contaminated material and eat it, they could get oropharyngeal tularemia. Then if they breathe in the bacteria, they'll get pneumonic tularemia, which is the most severe form of the disease. And they could get typhoidal tularemia really after any kind of exposure, and they just get generalized symptoms. There have also been increasingly recognized focal infections like meningitis, endocarditis, and septic arthritis. Next slide, please. So if someone is suspecting tularemia, what tests should be done? Serology is one option, but like many serologic tests, there are many nuances. Serology is ideally collected at least 2 weeks after illness onset because the antibodies aren't detectable until 2 to 3 weeks after the onset. Complicating it more, IgM and IgG usually rise at about the same time, and once they're increased, they may remain elevated for an extended time, maybe even several years. So that's not really helpful for testing for cure. And then positive serologic tests really should be interpreted in the context of compatible clinical illness and exposure. And false positive results by serologic testing can occur for many diseases, including tularemia. Nonspecific antibody binding can lead to false positives, mainly because of cross-reactivity to things like Brucella. Besides serology, F. tularensis can be isolated from clinical specimens, which could include scrapings of ulcers, conjunctival swabs, lymph node aspirates or biopsies, blood or respiratory specimens, and other things, depending on the form of the illness. The Minnesota Department of Health also has a laboratory response network PCR available. And we've also seen an increase in tularemia cases identified through new testing methods like Carius or 16S broad spectrum sequencing. Next slide. When examining a patient with tularemia, standard precautions are sufficient since there's no person-to-person transmission. Likewise, isolation is not recommended. Standard disinfection practices can be used. Next slide, please. So one of the reasons that we're talking to you is because historically, we've seen a median of about 2 animal cases and 1 human case per year. But we've seen a huge increase in the number of cases in the past few years, especially in animals. Every year since 2023, we've had a record-setting number of animal cases reported to us. And last year we had 33 animal cases, so much higher than that previous median of 2. And last year was also a record year for human cases, with 12 human cases reported. Unfortunately, other states have seen similar trends, and we don't really have a clear explanation for it, other than potentially climate-related changes. Next slide, please. Looking at our data, human tularemia cases are split pretty evenly between males and females. And really, the age range is everywhere from 1 to 91, so anyone can get it. Over 2/3 of our human tularemia cases are hospitalized, and when they are, it's for a median of 5 days. Next slide, please. And as I mentioned, tularemia cases can be diagnosed in a variety of ways. Here in Minnesota, F. tularensis has been isolated from cat bite and tick bite wounds, lymph node aspirates, and blood cultures. We've had cases be positive by IgG, IgM, or both. And we've had curious testing identify F. tularensis, and then cases went on to get additional testing after that. Next slide, please. Nationally and here in Minnesota, ulceroglandular and glandular tularemia are the most common clinical forms seen, followed by pneumonic tularemia. That makes sense since most of our cases are exposed through tick bites or through animal bites. Next slide, please. So last year, with our really busy record-setting human year, we saw every type of tularemia except for oculoglandular, and I'm really hoping we don't see that this year. And also as a side note, these numbers count probable and confirmed cases. We had another 5 or so suspect cases that very likely could have had tularemia, but they didn't meet our surveillance case definition. Next slide, please. There's been an increase in the number of pneumonic tularemia cases in Minnesota recently. Prior to 2024, we only had 2 pneumonic tularemia cases reported in the past couple of decades, shown here in blue, so 1 in 2017 and 1 in 2018. Then 2024 hit, and we had 5 pneumonic cases reported. And then last year, we had 4. So it's really turning into a worrying trend that we're trying to get people to be aware of. Next slide, please. And this really appears to be a true increase in pneumonic cases and not a surveillance artifact. Tularemia was not on the differential for any of the pneumonic cases. Really, it just looked like community-acquired pneumonia, or some actually looked like maybe potential cancer because of the lymph nodes in the lungs being swollen. So it was a surprise to clinicians when F. tularensis was identified in blood cultures or in the pericardial fluid or in the lung lymph nodes. So really interesting. Next slide, please. And basically all these pneumonic tularemia cases were likely exposed through landscaping or mowing the lawn. So here are some pictures of animal carcasses that MDH staff found while we were doing site investigations at the exposure site for a couple of these cases. This is a really subtle exposure that cases might not be aware of, and the provider likely wouldn't think to ask about either. Next slide, please. So having unexpected positive F. tularensis cultures can lead to lab exposures. I really appreciate this quotation from the Medical Research Council of England that emphasizes the pathogenicity of the bacteria, saying that being exposed to F. tularensis is an accident which seems to befall practically all laboratory workers. So with that, I'm going to throw it over to Dr. Barnes again.
Excellent. Thank you, Maria. So yeah, I'm going to talk about the laboratory side here a little bit, talk about the diagnostic capabilities here, and then kind of cover what you see when you get stuff on a report. Next slide, please. So as with many organisms, the nomenclature for F. tularensis is a little bit tricky. We have sort of the old nomenclature, as Maria mentioned, type A and type B, referring to F. tularensis and F. tularensis holarctica. As she mentioned, the type A, the FT tularensis, tends to show up in rabbits and other rodents, whereas holarctica tends to be more associated with aquatic environments. We've had cases in Minnesota that have been associated with beavers, for example. The one I want to draw attention to is the one on the bottom, so Francisella novicida. This is a very low pathogenicity organism, at least compared to other FTs. It is widespread. But nomenclature-wise, this is also validly known as F. tularensis novicida. This occasionally gets people into trouble when they get a FT novicida that shows up on their MALDI, and then everybody says, oh no, it's tularemia. It's not. If it comes up as the subspecies, then we're fine. Still worth a call, and I'll give you the numbers for that at the end, but always happy to take a call about that and kind of chat about what all that sort of means. But as you can see, just looking at these organisms, F. tularensis has a much higher relative virulence than the other ones, and that's the one we're mostly worried about. Next slide, please. So F. tularensis requires cysteine supplementation, so it grows poorly, if at all, on sheep's blood plates. Does not grow on MAC or EMB. Generally comes up on a chocolate plate like this seen here. One of the problems is that it's a little bit slow, so it tends to take kind of 48-ish hours to grow. And the colonies are pretty small. Even at 48 hours, there's still there's a bunch of them sort of past pinpoint, but some of them are still pretty tiny. They tend to be very flat, very smooth. And one of the things that gets laboratorians in trouble is it doesn't really look like very much. It's not very exciting. And so you just sort of look at it and be like, yeah, just something growing, probably some random environmental bug. Tularensis is a random environmental bug. It just happens to be one that we're sort of worried about here. So it needs a little bit of extra time, needs chocolate. It will grow on a sheep's blood most of the time. It just grows really slowly and really poorly. We sometimes see these take 4 or 5 days on a sheep's blood plate, and sometimes not at all. Just depends on the strain. Next slide, please. So this is where things get really tricky. So classically, we describe F. tularensis as a pleomorphic gram-negative coccobacilli. The problem is it is very variable as to how well it takes up the gram stain. So this is a very typical gram stain that you will see with F. tularensis, where there's sort of two interpretations here. The first is, oh, you have a mixed colony. You have some gram-positive little coccobacilli-like things and some gram-negative ones because you've got some purple stuff and some pink stuff. So you don't have a pure culture. Or the person doing the gram stain didn't do a very good job and had uneven destaining. And therefore, what you have is a technique issue. I've seen this in a lab where somebody who was relatively new did the gram stain and it looked like this. And the supervisor said, you did it wrong, please redo that. So they redid it and it looked the same. And the supervisor got frustrated and said, well, I'm just going to do it. And they did it and it looked the same. So this is really common. This does not mean this is what FT always looks like. Sometimes what it looks like is just little tiny gram-negative coccobacilli. But when I say tiny, I mean really tiny. These are little tiny pinpointy things. These are like brucella size or smaller. But this issue of really poor staining or really uneven staining is really classic for FT. So if you see this, stop and say, wait a minute, what am I looking at here? Because the place that we see a lot of errors happen is when somebody sees this and says, oh, well, it's mixed, so I'll just go ahead and restreak it. That might be appropriate, but you probably need to do that in a biosafety cabinet. Next slide, please. So on a biochemical standpoint, I tend to think of in my head as brucella as the thing that is mostly positives and the thing that in francisella is things that is mostly negatives. So it's oxidase negative, motility negative, nitrate and urea negative. Most people aren't doing the beta-lactamase at this point. Catalase is a little tricky. It's classically described as being a weak positive. The problem with that is that if you're kind of in a hurry, it can look like it's negative. So the catalase activity is relatively low, so you might have to let it sit there for a minute. Again, this should be done in a biosafety cabinet if you're thinking FT, because having something popping around on a catalase plate is not going to be a good idea if you are worried about inhalation. Automated testing is hard because since it's the select agent, most databases, whether they are databases for your classic automated instrumentation like a Vitek or a MALDI, don't have this data in there. The federal government doesn't want this to be easy for people with nefarious ideas to have an easy chance of isolating, so they don't have them in the database. The Viteks kind of classically pull these up either as H-flu or something weird like Aggregatibacter. So if you have something you're wondering if it's FT, please don't put it on an instrument. But if you do and you get a weird answer, please think about whether or not that makes sense. On the MALDI, you typically get something like an Oligella or a Cycrobacter. This is improving slowly over time, but MALDIs are still not a great choice here. We often talk about not MALDIing these things. Again, if you think it's FT, the issue is not that there's exposure in the instrument. The issue is that many places are still doing their prepping their MALDI plates on the open bench. So if your lab does that, definitely don't do this. If you do it in a biosafety cabinet, maybe call us and talk about it first, because I'd rather get these and save you guys the exposure possibility than run the risk of exposing it to people in the lab. So in general, don't do anything that generates an aerosol. Don't do anything out in the open bench. Don't use automated systems unless we've talked about it. Next slide, please. All right, so this is just so it's in the slide deck. This is the standard flow chart for Sentinel Labs to figure out should they be sending us stuff or calling us. Just as a reminder, because I occasionally get people confused about this, with all of these kind of flow charts, you start at the top. You can't start halfway down. So first of all, you have to say, like, does this match colony morphology? Is it small? Is it shiny? Is it gray? Does it look pretty flat? Does it grow pretty slowly? Does it need cysteine? And then you go look at the gram stain side. Is it tiny? Is it mostly gram-negative coccobacilli or mixed or poor staining or something like that? If that's true, then you go down the oxidase side. If that's negative, you need to do whatever your lab does to rule out Haemophilus, because those Haemophilus can look like all of those things. But if you rule out Haemophilus, then you continue on down the chart. And if any point on this chart you have questions, just call us. I'm even fine getting calls from people who are saying, well, I have a colony morphology that's weird and a gram stain morphology that's weird, and I want to talk to somebody. That's totally fine. I would much rather get calls about that than get a call later saying, oops, we accidentally put it on the MALDI and now half the lab is exposed. So save yourself the pain of that. Just give us a call. We can chat. We can talk about what the next steps are. Because that's really a good place to sort of pull that information from, is from your first ID part. But that's the flow chart. Next slide, please. So testing we do at MDH. So we certainly can do stuff from whole blood and tissue, but that's not typically where we see this. Because again, usually people aren't thinking FT when they send us a specimen. They're actually have grown something on a plate, and that's why they're worried about FT. So typically we're looking at an isolated colony, something that has a nabbed suspicion by just being there and growing. The way we classically do these is that we do a first step RT-PCR, which gives us the speciation, gives us the genus, says that this is Francisella. That usually takes, we cite 4 hours, and that's a little bit faster, but 4 hours is pretty typical. Then we will run a subspecies oxidation on that to actually figure out which subspecies it is. If we have a high likelihood that this is an FT, say this is from a necropsy from an animal that had spleen lesions or mouth lesions in addition, or from a human patient that has a known exposure to a cat or some other zoonotic exposure, and they have a really high fever, we'll probably run these both at the same time. save ourselves a little bit of time. But that's the RT-PCR, that's the molecular side. And then after that, we will do culture. Typically, if we're just subculturing this from a plate, it'll often come up in a day, but it can take up to 3 days. It can get a little bit slow. But we need to get that culture to make sure we actually have a live organism and something that's growing, because for the select agent reporting, that's going to be a thing with all this. We have classically done a direct fluorescent antibody assay with this as well. We're in the middle of switching that off. We are still testing for it today, but that'll be going away relatively soon. LRN has discontinued that test. And so we're just doing it as we can finish wrapping up our new validation verification for the new testing. But DFA is still part of what we do right now, so that'll be going away soon. Next slide, please. So looking a little bit closer at the plate, I do want to sort of mention that we do some other kinds of growth here as well to try to get a better sort of colony morphology. We grow these on chab plates. And that's mostly because if you look in the middle, even when we're growing it, this is what we typically see, which is just these little tiny colonies that are all kind of smudgy and hard to tell what they are. We get a much better differentiation on a defined media. Some labs use BCYE because, again, that can actually provide some differentiation. And it's also because this is a nice white little colony that grows or grayish, shows up really well in the dark background of the BCYE plate. This is not a thing. This is more for interest. I'm sort of pointing out this is what this looks like. I'm not suggesting anyone should jump out and say, "Hey, let's start doing BCYE cultures," because no, I would like you to call me if you see something weird, not go down the rabbit hole of growing it on lots of different media to see what you get. But again, grows poorly or not at all on SBA. MAC and EMB also are not supported for growth. Next slide, please. So this is what they look like on the DFA. This is mostly just a pretty picture because I like pretty pictures. But this is what the polyclonal antibody with the FITC label on it looks like when it's done really well. This is a great picture. But as you can see, they are little coccobacilli. There is some range of sizes here, and that's pretty typical that what you see with FT. Not a huge range, but enough that it can sort of throw people every once in a while. Next slide, please. So I want to make sure we're sort of talking as well about differentiating FT from other things. So the classic things to differentiate FT and Brucella, because again, remember, they can look kind of similar on the plate, and they can be a little bit sort of awkward to tell apart depending on how the D stain worked for the FT on the gram stain. But Brucella is going to be both oxidase and urease positive, whereas Tularensis is going to be negative for both. The thing that's a little bit tricky is you have to sort of think about how small these really are. So Brucella, I usually consider to be tiny. It's smaller even than Haemophilus is or Pasteurella. F. tularensis is really tiny, like it's extraordinarily small. So it can be hard to tell that under the scope sometimes when you don't have a direct comparison, but think of that in your head, like, hey, this looks really, really small and it's not staining well and it's got some funny stuff on the plate. That's the time to stop and call. Don't be a hero on that one. Gets a little trickier when some of the other assays are considered here because these are all negative for motility. Haemophilus does have the factor X and V requirements, but I mean, a lot of people aren't necessarily thinking about that at this stage. The biochemical thing you're going to look at is whether or not it requires cysteine for growth. This is still a little tricky because, especially during a subculture, sometimes they'll grow a little bit on the SBA, and that can be a little bit hard to tell. But if they're growing robustly on the sheep's blood plate, not thinking Tularensis at that point. Next slide, please. So other testing is available, as Maria sort of mentioned. There are serologies that are available. This is a pretty variable clinical utility, as she talked about. It's definitely not useful as a test for cure. We do have cross-reactivities going on, and this is really a solid 2 or 3 weeks before most people see either an IgM or an IgG. ASTs are sometimes requested. Honestly, they're not terribly useful. Much like in Brucella, antibiotic resistance is relatively rare, and this is a thing we just have to send out to CDC to do. I think we've maybe sent out 1 or 2 of these in the last several years total. Because again, things like Gent and Cipro and Doxy work pretty well. Doxy is a great place to start. And a lot of this is just because the biology of the organism doesn't really support easy changes in resistance. So next slide, please. All right. So now I'm going to turn it over for a little bit to Eric Lundquist, who's our biosafety coordinator here at the lab, to talk about what laboratorians can do to stay safe when they're working with this organism, and more generally for biosafety cabinet use as well. So Eric, take it away.
All right, thanks, Aaron. And just to reiterate what Maria said, happy Lab Week to everybody. Definitely one of my favorite weeks here at the Department of Health. And when I work in a clinical lab, also one of my favorite weeks. We can kind of celebrate ourselves a little bit. So a lot of my stuff isn't new. It's stuff I've talked about before, but we continue to see exposures in laboratories around Minnesota, including very recently. And so it just bears repeating. Next slide, please. So I'm not doing this discussion isn't on risk assessments, but I'll start with the definition. It's the process of evaluating risks that arise from agent and lab hazards, taking into account the adequacy of existing controls, prioritizing those risks, and deciding if the risks are acceptable. And that is from the BMBL. I hope you're familiar with that. I'll talk a little bit more later. Risk assessments are the most important part of biosafety in a lab, without a doubt. Without them, labs just throw a bunch of PPE or SOPs at a problem and hope that it works for all processes. That might work, it might not work, and it might make things worse. Adding PPE sometimes increases risk. The BMBL is the source of a lot of the biosafety guidelines that we use in the lab. There are other sources, and like the WHO Safety Manual, 4th edition. I'm willing to share more if you contact me, but this is a great place to start. And I'll just go over some of the basics. So next slide, please. So who does risk assessments? Assessments, a multidisciplinary or disciplinary team. So lab staff. This is, again, most important group is the group that is actually performing the work. Hopefully a biosafety person, at least to go over it after, if nothing else, but to give you considerations you might not think of. Infection preventionists can be helpful. It depends on your infection preventionist. Some are better with lab safety than others. Management or supervisors should always be involved. And the reason is because any changes you need to address, you need to get their buy-in. But if you are in the leadership role, it's important to remember that your staff should be leading the risk assessment, not you. You don't do the testing. And then facilities. Sometimes you need facilities help. And I could give examples, but you'll know it when you need it, especially if it involves airflow. They also need to be done at each lab. So if you're part of a system, it's impossible to do a risk assessment for your entire system. If you've seen one lab, you've seen one lab. And even in your system where you do everything the same, your labs are very different, your personnel are different, you need to do different risk assessments. And sometimes the mitigations are going to be different. Next slide, please. So here are the sheets that we use. I've got, I think, 3 slides of sheets, but we do a full hazard analysis first. And we do this because, if you're doing a risk assessment, you might as well look at everything, chemicals. It's not all about biosafety, even though that's what we're talking about today. And so we start with this. We've got a lot of check boxes. It gets people thinking because we list a lot of the sources of problems on these sheets. Next slide, please. We go on to, this is still that same sheet. It just was too big for a couple pages. It doesn't matter that it's small on here. This is just to give you guidance, not that you have to read it all right now, but we include chemicals. Here we have to include radiological risk. We do things like ergonomics, again, as long as you're doing it, you might as well do it all. And then click the next slide, because this last part is the most important. So we always ask this question at the end: are there sufficient mitigations in place essentially already to minimize the risk of all identified hazards to an acceptable level. This question is almost always no, but you should also, if it's yes, we would be done. But if it's no, we go on to a summary form. And also, whenever we have a new procedure, we do this summary form. So next slide, please. And on this one, you're probably going to notice, this is more what a risk assessment form looks like to most labs that have them. It includes, we look at the agent, the infectious dose, all those things Maria kind of talked about before, how it's transmitted, the risk group, and then we include any of the other risks that we might have seen on that hazard assessment. So we start with the procedure or each step of a procedure, and then we talk about the test or the task, the hazard, and then the control or mitigation that's done. It can also be helpful to put kind of the risk level before or the risk level after you make any changes. It shows, if you need meaningful information for supervisors to show that you've addressed risk, you can add those columns. And again, we use the BMBL a lot for a lot of our guidelines. Next slide, please. But another great tool is the risk group database from ABSA, the American Biological Safety Association. It's a great tool. It's available on your desktop or as an app on your phone. And what I love is it includes these 9 sections on there, but most importantly, it links to the Canadian pathogen safety data sheets. And, I love the Canadians. Besides maple syrup, they're also really good at categorizing risk. And so, don't reinvent the wheel, use tools that are available. And next slide, please. So again, it is my favorite tool. It gives you information in all of these categories: infectious agent, health hazard, how it's disseminated, the viability, medical considerations, lab hazards, etc. It's a gold mine of info. It is free also, and so take advantage. Next slide, please. So Francisella tularensis, like Aaron said, it is a select agent. And speaking of select agents in general, how do you stay safe when you might encounter a pathogen like FT on the first read only once or twice in your career? Use trigger points. And so a trigger point is those little aha moments when you're looking at cultures and you think, I need to do something different with this one. It just triggers something in your head. Whenever you feel that in your gut, the first step is to always go to a biosafety cabinet. Let's see, anything that's poor growth, like Aaron mentioned, after 2 to 3 days, any growth from sterile sites, anytime that you see gram negatives, especially that are on the initial gram stain and then they have no growth, that should be a trigger point. If it only grows on chocolate or grows better on chocolate, and then any molds. And again, the BMBL, I mentioned this, a lot of times, and the electronic version is free. And most importantly for you, the newest 6th edition, for the first time ever, has a clinical lab section. And so that's neat that clinical labs are now being considered. It's not just research and universities and public health labs anymore. It is still important to read those other sections, particularly, how does work in a BSL-2 and BSL-3 go? Those are great sections. So next slide, please. So trigger points don't do any good if you don't give your coworkers tomorrow a heads up. Ideally someone would look at the work card before they start work, but that doesn't always happen. So manipulate all blood cultures in a biosafety cabinet. You know, if it comes up positive on your instrument and you have to inoculate your plates, always do it in a BSC. Tape plates on positive blood cultures that are slow to flag positive. So they, you know, they come positive after 2, 3, 4 days. Just tape those right off the bat. Read all day one blood and sterile site cultures in a biosafety cabinet. If you see gram variable coccobacilli or tiny GNB on any sites on initial gram stain, tape the plate shut before incubating, read in a biosafety cabinet. And then if you don't set up chocolate agar on everything, consider setting up chocolate agar whenever you have a culture that involves an animal or tick bite, or in any culture with gram variable or tiny GNB on the initial gram stain. So on these considerations, I was at the vet a couple weeks ago, and you know, animals, you know, cats, rabbits, etc., dogs have a higher prevalence, and I'm there. My cat is just there for a checkup, and I see the vet, you know, uncapping a syringe, recapping it with her mouth, and I love my vet, and you might just think vets are crazy, and they, you know, and a lot of times they kind of are. They've got less resources, they've got a lot of patients to see, and you know, they're great people trying to do the best, and sometimes the biosafety isn't always there. But lab people are just as crazy. I still see people sniff plates. People proudly talk about sniffing plates. I still see people, the last lab I was in, still no gloves, and sometimes still no safety glasses. And so to me, those are just as bad as the syringe in the mouth thing. So don't sniff plates. If you have to go around and ask coworkers about an organism, like you know, hey, what do you think this is? What do you think this is? That's great. That's what we do as microbiologists. Look at it in a biosafety cabinet. If it raises suspicions, look in a biosafety cabinet. Next slide, please. So again, when in doubt, like I just said, use a BSC if available. And especially for aerosol producing procedures, catalase, basically pretty much any manipulation you do of a culture creates an aerosol. And so if you're unsure, do it in a BSC, but pipetting and aliquoting always. Any heating of anything, any vortexing, do it in a biosafety cabinet. And again, when you're suspicious, your subculturing and then your gram stain should also be prepared in a biosafety cabinet. Next slide, please. So finally, your biosafety cabinet should look like the one on the right and not the one on the left. Both of those are real biosafety cabinets that I came across. And you need to keep the front and the rear grille clear, or as clear as you can. Avoid clutter. Only bring in, I can't stress this enough, only bring in what you need to complete the job you're doing. And then disinfect things on the way out. You don't need to stock supplies for tests that you do once a week. You don't even need to stock things for the entire day. Maybe for your shift, maybe just for the task you're doing, but limit what you bring in. You also don't want to stock so little that you're coming in and out of the biosafety cabinet during the same procedure. So it goes both ways. Be mindful. Bring in items that can be easily disinfected. So no boxes, no paper, etc. Any porous materials. If you have further questions, contact me. If you would like me to visit your lab, contact me. I go out to labs. When you have these problems, there's almost always an easy way to fix it. And sometimes it takes someone from the outside to look at that. I can help you with lab audits, with risk assessments, including providing forms if you need them. I can do biosafety cabinet training, high consequence pathogen exposure evaluation, PPE selection and training. A couple of newer things. Through APHL, I'm on the Biosafety Biosecurity Committee, and late last year, mid last year, we developed the instrument pre-purchase risk assessment. It is, for anybody that buys instruments on here, you spend a ton of money and they don't tell you any information about it except what looks good to them, to the manufacturer, what'll sell the instrument. They don't talk about biosafety and stuff. And so we've got a list of questions to ask, other considerations. And then just yesterday, we got published another checklist that we made. It's handling specimen suspected. I'm reading this because it's a long title. Handling a specimen suspected of containing a high consequence pathogen, a checklist for clinical laboratories. And what this is, there's the National Special Pathogen, what's the other S there? NSPS. And it used to be NETEC, it stemmed from the Ebola stuff. And so the Ebola patient is never going to present at the West Bank of Fairview, where we have a treatment hospital. They're not. They're going to show up at your lab. And so how can you prepare in advance? NSPS has a lot of great tools. They don't have great tools for laboratories. I know you guys know all about that because it's normal. So we developed a tool for labs, and Tori Nemitz from the West Bank and I are going to be talking about NSPS in general at MEMA on June 9th. So if you want to learn more, that's all for me, and I'll hand it back to Aaron.
Perfect. Thank you, Eric. Just as a follow-up to that, just because I don't think he said it explicitly, if he comes out and looks at stuff for you, he's not doing that in a regulatory capacity. He's doing that as an advisory capacity. So don't feel like he's going to come out and find stuff and then ding you for it. He's just out there to help. So take him up on that because he's good at it. Okay, just a couple of quick things to sort of wrap up here. Just a reminder for people about the reportable disease rule in Minnesota. I'm hoping that every lab has at least 2 or 3 of these posters sort of sitting around, stuck up on the wall somewhere. If you have one that's more than a couple years old, you can go to our website and grab the new version or whatever. I think we even still send them out if you want a printed copy. I did see one a couple months ago in a lab that was about 10 years old, and things do change, so better to have a slightly newer one. But just a reminder here, so there's 2 categories we're worried about here. There's the report within 1 working day, which is the vast majority of things we're interested in about. And so that's fine to let it, please don't let them sit any longer than you have to, but the requirement is just you report them within 1 day. Report immediately by telephone, the stuff at the top. This is the stuff that we're much more worried about. This is stuff like Bacillus anthracis. This is stuff like botulism toxin and things like Coxiella. Some people sometimes ask me, oh, what does report immediately mean? My rule is don't go to lunch. If it needs to take half an hour to sort this out with a supervisor or a lab director or whatever, that's fine. But it should happen in the same half of your shift that you're telling us about it. For most of these, especially in the report immediately by telephone, we're going to need some patient specimen as well, whether that's a plate that you have or some other a blood sample or whatever, because we're going to have to try to do an isolation and get a confirmation for you. Numbers are listed there for immediate reporting, and then the report forms are available on the website, as you can see right there. Next slide, please. So just sort of a summary of the kind of stuff we've talked about here. We have been seeing these increased rates of tularemia, notably in animals, even more notably in humans. We are kind of pretty definitely at a 5 to 10-fold increase over sort of 2022 and earlier. And this seems to be sort of a real increase, not just a sort of better surveillance sort of system. Given that this is the case, we're asking that clinicians and laboratorians have a elevated level of concern for F. tularensis cases. For clinicians, this would particularly be if you have a patient who looks like they have community-acquired pneumonia and it's not getting better on the first round of antibiotics, stop and think. If you have a patient who doesn't really have an exposure history that makes sense for community-acquired pneumonia, or it's in the middle of the summer or whatever, ask a few more questions there. And for laboratorians, please make sure that you're sort of doing the thing Eric talked about, which is that if you get that funny feeling in the back of your neck, like this is kind of weird, stop, go to a biosafety cabinet, and think about what to do next, whether that's talk to supervisor, talk to your lab lead, whatever. But it's, or if you're the lab lead, then give us a call. But yeah, have that elevated level of concern, because this is not a sort of once a year thing anymore. This is we get a whole bunch of them in the summer now. So as Maria mentioned, while we do have hotspots here in the Twin Cities, kind of by the chain of lakes and over in Cottage Grove and some on the north side, this is really an entire state kind of issue. We've had stuff from all parts of the state. We've had tularemia cases from everywhere. Sentinel labs should follow that ASM guideline. Make sure anything that's hitting those concerning values, give us a call about. And again, I am always fine to get a call where it's like, you know what, I don't know what I'm looking at here. Let's talk about it. Because a 5 or 10 minute call could save you a lot of work on the downside end if you have an exposure. And as Eric mentioned as well, there are some biosafety issues here with F. tularensis, mostly because of its really low inoculum level. You can get sick from 10 organisms. Doesn't take much. That's not quite as infectious as things like TB, but it's getting pretty close. And practically, there's really no difference. So while there may need to be some sort of minor changes in workflow, we need to do this so we can keep laboratorians safe, because that's our goal here. Next slide, please. So this is how you get a hold of us. If you have a question from an epidemiology standpoint, they have a 24/7, 365 phone line to talk to. Sometimes it's an answering service that will then forward your message on, but you'll get a call back pretty darn quick. If you have questions about lab-related stuff, you have a specimen you need us to do a rule out on, you have some biosafety questions, you can give our biothreat on-call phone there. There's 2 of the 3 people who carry that phone are on this call right now. So we answer this any time of the day or night. We'd prefer to get a call in the middle of the day if you know you have something at that point. But if it's 2 a.m., it's 2 a.m. And I'd much rather hear about it then. So contact information for all 3 presenters is down here. We're always happy to take questions. And with that in mind, that's end of our talk here. And if there are questions from folks, we're happy to take those at this point. Thank you. I'm actually going to guess that we're not going to have any questions, just because usually people just email us at the end, which is totally fine. So I won't make everybody just sort of sit here and watch, but you should get an email with the information about the PACE credit stuff if that was of interest to you. We'll get that sent out. And otherwise, thank you very much for participating, and we look forward to seeing you on the next call. Thanks, everybody. Bye.